Good evening, dear colleague and distinguished guest. I am Dr. Atanu Acharya, and on behalf of the entire Sonoscan team, I extend a warm and heartfelt welcome to you all to today's academic session on the critical aspect of diabetes and thyroid management. Our mission at Sonoscan has always been to support medical community with cutting-edge diagnostics, and we believe that fostering collaboration and the free exchange of knowledge is essential in giving advanced patient care. Thank you for your gracious presence, and we wish you a very engaging and insightful session ahead. Now I take privilege to introduce our honorable guest of this evening. At first, I would request our chief guest of today's session, respected CME of Malda, Dr. Sudipta Bhaduri, to take his chair on the dais. Sir, please. Apart from his huge administrative responsibility, Sir always finds time to encourage the academic activity. So very thankful, we are very much thankful to you, and we are deeply honored to welcome you, sir. Next, I request our guest of honor, Dr. Uttara Chatterjee, to take her chair on the dais. Please, madam. Professor Dr. Uttara Chatterjee, she is MD in pathology from AIIMS, New Delhi, and DRC Patho London is a name synonymous with excellence in pediatrics and neuropathology. She is the professor and head of the pathology at IPGMR Kolkata and a brilliant academician who has authored over 180 scientific publications in reputed international journals. It's a privilege to welcome her on this platform. I now request our guest of honor, Dr. Mithali Chatterjee, to kindly take her seat on the dais. Professor Dr. Mithali Chatterjee, she is MD in pharmacology and PhD from the Indian Institute of Chemical Biology, currently professor and head of the pharmacology at IPGMR Kolkata. She is internationally acclaimed for her pioneering research on leishmaniasis and immunopathology, and is a fellow of the Indian Academy of Sciences. We would be very much honored to have her amidst us. Now may I request our today's torch bearer of the session, Honorable Sir Dr. Sudip Chatterjee, to come on the dais and take his chair. Sir, please. Dr. Sudip Chatterjee, MD Kolkata, MNS Endocrinology, FRCP London, FSCP USA, a name that commands respect across the field of diabetes, metabolic and thyroid medicines. He serves as an honorary professor of endocrinology at VIMS, Kolkata, and also the secretary of the Historic Park Clinic, Kolkata, a name recently linked in proud collaboration of Sonoscan Healthcare. His research on acromegaly led to the improved treatment outcome. Is published in the Lancet also. He has anchored numerous publications and book chapters on various endocrine topics. We are privileged to have him as a guest speaker, and he would share his insights on the management of hypothyroidism in special situation and the latest ADA guideline in the diabetes care. Thank you, sir.
আজকের এই সায়েন্টিফিক সেশনের মডারেটর আমাদের খুব প্রিয় প্রখ্যাত ডাক্তার ডক্টর অতনু আচার্যকে আমি অনুরোধ করব স্যার একটু চেয়ারে আসবেন, আপনাকে আমরা ফেলিসিটেশন করব।
May I now request our honored guest to share their insights on today's academic session. To begin with, may I invite our CME Dr. Sudipta Bhaduri to the microphone to address the gathering. Sir, please.
Good evening. Perhaps we are meeting quite frequently. We are privileged, and I am extremely honored as a Chief Medical Officer to invite the torchbearers of our fraternity to the district of Malda. For the last 2.5 years, when I have joined as the Chief Medical Officer, I found that the CMEs, be it held by IMA, be it held by some companies, be it an IEP, be it API, just could not attend and could not attain the desired height of filling of a room, which I am sure that in the same hall when I will come next Sunday for another academic session here, already the registration, you all know that it has crossed the total capacity of this room already. So this medical growth of medical education, not only for our practicing doctors, I encourage my junior medical officers in the field so that they come, they learn, and they attain some concept of higher and more thoughtful updates of recent healthcare. Sir, madam, আমরা যখন ছোট থেকে বড় হই কিছু নাম কিন্তু থেকে যায়। কিছু কিছু কনভারসেশন এখন ইউটিউবে দেখবেন লিগ্যাসি কনভারসেশন, এই ধরনের টার্ম দিয়েও আপনারা সার্চ করলে পাবেন। যখন ছোট্ট ছিলাম এক্সাইড মোড়, রবীন্দ্র সদন, সেই অঞ্চল দিয়ে যখন আপনারা যাবেন, পার্ক স্ট্রিট অঞ্চল যখন যাবেন, কিছু ক্লিনিক আপনাদের মনে থেকে যায়, কিছু মানুষ আপনাদের লিগেসিতে নিয়ে আসে। আমরা যখন ছাত্র তখন থেকেই কিন্তু প্রফেসর সুবীর চ্যাটার্জি কিন্তু ছিলেন এই ভারতবর্ষের এই অংশের পেডিয়াট্রিক সার্জন, প্রথম বাচ্চার শরীরেও যে শল্য চিকিৎসা করা যায় তার প্রতিকৃত। দুই স্যার, we have lost Dr. Sandip Chatterjee, one of the finest neurosurgeon the country has ever produced, but we have got Dr. Sudip Chatterjee today, one of the finest, renowned ছোট্ট থেকে চাকরি জীবন কেন, যখন ডাক্তারি জীবন কিছু নাম যারা ভাসতো, কোনোদিন ভাবিনি তার পাশে স্যারের পাশে বসে একসঙ্গে কোনো একটা মিটিং আমরা এগোতে পারবো। অ্যান্ড দিস ইজ লিগ্যাসি। স্যারের ব্রাইটফুল স্পিচ আগামী দিনের যারা ইয়াং ডাক্তার, যারা সিনিয়র ডক্টরস, যারা স্টুডেন্টস আছেন, যারা এসআররা আছেন, আগামী দিনে ডেফিনেটলি it will be a torch bearer for them. For sir's knowledge, sir, we have started the juvenile diabetes in Malda, screening of juvenile diabetes, and it is directly monitored from IPGMER hospitals. We are doing the clinic here. Presently, we are just following up the patients of Malda attending IPGMER. And we are now just expanding to our field level. We are training our CHOs, we are training our doctors for referring the patients to the juvenile diabetes clinic. MSBP Malda Medical College is also here. Hopefully, the newer challenges, the endocrine problems, endless knowledge, it will be addressed and we will be enlightened for that. Regarding Professor Mithali Chatterjee and others, Madam is our actually team lead in the Kalajar elimination program, and you know that Malda is now at the certification level of the Kalajar elimination, and in this month itself, Government of India, Chief of WHO from India, the national visit is going to happen within 15 days in Malda. We are now getting ready for that visit, and definitely within this year the international visit will happen, and from next year we will go for the certification for Kalajar elimination, at least in the district of Malda. So ma'am is the team lead. We communicate through emails from the IPGMER. And biochemistry, pathology, all the clinical subjects, I am really humbled to be present in front of you. But from the heart of the district, from the heart of the medical fraternity of this district, I request you all and welcome you all to Malda, so that, and repeat coming to here. I also said this with the last seminar I held here with Dr. Abhijit Choudhury on the fatty liver. The same thing, I will tell it again in the next week when other eminent persons will come for a long 4 credit hours West Bengal Medical Council credited CME next week. Thank you very much. Please keep join with the government health system. No government health system without a private backup can flourish. No private backup without a support from government can flourish. And we have to flourish to make a Malda proud. We cannot win over the fight between whether I am a private or a government. The knowledge, the MBBS, the womb from where we have come are all the medical colleges of our state or the country. So we are brotherhood in that same blood also. Thank you very much and have a nice evening.
Thank you, sir, for your kind words. May I now request Dr. Uttara Chatterjee, our guest of honor, to address the gathering.
I'd like to thank Team Sonoscan for inviting me here. It's been a wonderful experience. I had the opportunity, I work in IPGMER, but I had the opportunity to see the pathology lab today. It is a wonderful state-of-the-art lab with all best of modern machines, the doctors, and it has so much in the field of hematology, FNAC, histopathology, clinical chemistry. What I saw, the first thing I told Dr. Roy is that you should have DNB students. You should have DNB students who will be benefited with so much material. So I'm very impressed with the lab here, and I wish Team Sonoscan all the best. Thank you.
Thank you, madam, for your kind words. May I now request Dr. Mithali Chatterjee, our guest of honor, to kindly share your reflection and words of encouragement for us.
very good evening to all of you. Today we are here in November 2025. I would like to take you back 100 years ago, almost 100 years ago, when Sir Upendranath Brahmachari identified that Kala-azar has a form which appears, a dermal lesion which appears in some cases of Kala-azar, and that he called as post-Kala-azar dermal leishmaniasis, or PKDL as we know it. So this is important because today in 2026, as the respected CMOH said, that we are now at the point when we can say that we have been able to cure almost every case of Kala-azar, identify every case of PKDL, and make elimination of Kala-azar and PKDL a reality. In this particular scenario, Malda leads the way for us because the support that we have received from all of you, every case has come to us. We have been able to support you. You have referred the case to us. Amra field visiteo eshechi ekhane, and it has really been a learning experience for all of us. So it is something that we should all feel proud about. You, the doctors here, are something we are really grateful to, because together we can say that finally India will be rid of a disease like polio. Elimination of Kala-azar will soon be a reality. So thank you to all of you, and thank you and all the very best. It has really been a pleasure to be here and be a part of this organization. Thank you very much.
Thank you, madam, for your kind words. Now I request Dr. Shapun Rai, on behalf of Sonoscan, to say a few words.
আমাদের এখানে যারা আপনারা আমার থেকে বয়সে বড় এসেছেন সময় নষ্ট করে, এবং আমার থেকে ছোট সবাইকে আমার নমস্কার জানিয়ে আমি দু চার কথা বলতে চাই। আমার এখানে কথা বলার কোনো কথাই ছিল না, অতনু বলল কিছু বলার জন্য। অ্যাকচুয়ালি আমাদের মঞ্চে যারা আছেন ডক্টর সুদীপ চ্যাটার্জি, ডক্টর উত্তরা চ্যাটার্জি এবং আমাদের ডক্টর মিতালি চ্যাটার্জি, এনার আইডেন্টিটিটা হচ্ছে 1 নম্বর চ্যাটার্জি পরিবার, 2 নম্বর হচ্ছে পার্ক ক্লিনিকের, ওনারা হচ্ছেন সমস্ত কিছু। তা গত বছরের ডিসেম্বর 15 তারিখে আমি ব্যক্তিগতভাবে ডক্টর সুদীপ চ্যাটার্জির সঙ্গে করি, কারণ ওনারা একজন কাউকে চাইছিলেন যে পার্কটাকে পরিচালনার দায়িত্ব দেওয়ার জন্য। তো স্যার আমাকে বললেন, আমার কাছে তো অনেক 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 বড় বড় কোম্পানি বা প্রতিষ্ঠান এসছেন, তা আমি সবই শুনলাম। তারপর থেকে দেখলাম 1-2 সিটিংয়ের পর থেকে স্যার দেখলাম অন্যদের সবাইকে না বলছেন, আর আমাকেই কথা বলে যাচ্ছেন। স্যার আর আমি দফায় দফায় বিভিন্ন লয়ার, চার্টার্ড অ্যাকাউন্টেন্ট, হাউ দ্য প্রসেস উইল বি ডান। স্যার চাইছেন প্রতিষ্ঠানটা যেমন ভালো থাকে, আমি চাইছি প্রতিষ্ঠানটা নেওয়ার পরে যেন ঠিকমতো পরিচালনা করা যায়। তাই পার্ক ক্লিনিক গত 25শে সেপ্টেম্বর অফিসিয়ালি আমাদেরকে স্যাররা দিয়েছেন, মানে পার্ক মেডিকেল রিসার্চ অ্যান্ড ওয়েলফেয়ার সোসাইটি, যেটা পার্ক ক্লিনিক নামে পরিচিত, 92 ইয়ার্সের হেরিটেজ। আমার এই চেহারা দেখে বা বাঙালি কথা শুনে, আমি বাঙালি অস্মিতায় ভুগি, তা সে নিয়ে স্যার কেন পছন্দ করেছেন আমি জানি না। তারপর আমার মনে হলো স্যার তো দিয়েই দিয়েছেন, একবার স্যারকে নিয়ে মালদাটা ভিজিট করাই। তাই আমি ম্যাডাম উত্তরা চ্যাটার্জি, মিতালি চ্যাটার্জি এবং স্যারকেও সবাইকে বললাম আপনি আসুন। স্যার খুব ভালো বক্তা, এন্ডোক্রিনের খুব সুন্দর বলেন। তা আমি স্যারকে বললাম, স্যার একটা আপনি যদি সেমিনার করেন খুব ভালো হয়। তো স্যার আমাদের দায়িত্ব দিয়েছেন। আমি কিন্তু আপনাদের, মানে আমাদের যারা আছেন এই সোনোস্ক্যান পরিবারের সঙ্গে নয়, সবার সঙ্গে, আমাদের তো মালদার ডাক্তারবাবু, মালদার মানুষ, সোনোস্ক্যান এবং মালদা নার্সিংহোমের উপর আমার দাদা অসুস্থ, মানে দাদা হচ্ছে পায়োনিয়ার, যিনি 1984-এ মালদা নার্সিংহোমের ভিত্তি স্থাপন করেছিল, একটা 5 বেডের নার্সিংহোম দিয়ে জার্নি শুরু করা। আর সোনোস্ক্যানের জন্ম হয়েছিল একটা 150 ফুট ঘরের মধ্যে 1990 সালে। তারপর থেকে আমরা কাজ করে গেছি, পিছনে ফিরে তাকাতে হয়নি, কারণ ডাক্তারবাবুদের এবং আপামর জনসাধারণের সমর্থন আমরা পেয়ে গেছি। একটার পর একটা নতুন জিনিস এসেছি, একটার পরে যায় কাজ করতে গেছি। মালদায় কাজ করতে গিয়ে মনে হয়েছে মালদার বাইরে কাজ করি, দক্ষিণ দিনাজপুরে গেছি, গঙ্গারামপুরে গেছি, কলকাতায় গেছি। তারপরে যখন পার্ক স্যার প্রায় দিচ্ছেন, আমি কিন্তু একদিন স্যারের চেম্বারে বসে আমার চোখ দিয়ে জল বেরোচ্ছে। স্যার মনে পড়েন আপনার কথাটা? আই ওয়াজ লিটারেলি ক্রাইং, যে যে উনি আমাকে দিচ্ছেন যেমনভাবে, আমাকে মিনস আমাদের প্রতিষ্ঠানকে, আমার কোথাও ভুল হচ্ছে না তো, আমরা ঠিক করে চালাতে পারবো তো? কারণ ওনাকে ডিস্ট্রেসে ফেলা তো আমাদের টার্গেট না। পার্কের যে সুনাম, আমি তো জানি, আমি পার্কে স্যারকে মানে আমি আমার মেয়ের অপারেশন প্রফেসর সুবীর চ্যাটার্জির হাতে হয়, এখানে একটা হেমাঞ্জিমা লিপ ছিলেন, আমার দেখেছিলাম স্যার অপারেশন করে বেরিয়ে আসছেন, স্যার কিন্তু জানেন না আমি ডাক্তার, করে সব কিছু হলেন, কোথায় তারপরে স্যার খবর পেলেন, একটি পয়সাও নিলেন না, শুধু দুটো ইঞ্জেকশনের জন্য পয়সা নিয়ে ছাড়লেন। এটা দিয়ে পার্কের জন্ম, তারপর তো স্যাররা এসেছেন, চালিয়েছেন। এর যে ঐতিহ্য, এটাকে আমরা ক্যারি অন করতে পারবো কি না, এ নিয়ে আমি কিন্তু প্রচুর দ্বন্দ্বে ভুগেছি, কয়েক মাস ধরে ভুগেছি। স্যারকেও আমি টাইম নিয়েছি, স্যার হয়তো বোঝেননি বা বুঝেছেন। তারপরে জুন মাস থেকে আমরা কাজে গেছি আনঅফিসিয়ালি, সেপ্টেম্বর থেকে অফিসিয়ালি উনি হ্যান্ডওভার করেছেন। আমরা এখন কাজটা নিয়ে শুরু করেছি। আমরা এই দায়িত্ব পালন করতে পারবো কিনা আমি জানি না, চেষ্টা করব। সময় সব কথা বলে। আমি আপনাদের কাছ থেকে এটা এই অঙ্গীকারবদ্ধ নিচ্ছি যে আপনাদের প্রতিনিধি হয়ে, মালদার মানুষ হয়ে আমি কলকাতা শহরে একটা বড় কাজে হাত দিতে গেছি। আমরা আপনাদের সম্পূর্ণ সহযোগিতা, আশীর্বাদ আমি চেয়ে আমার বক্তব্য শেষ করছি। আমি বাপ্পাদাকে কিছু বলতে বলবো না, না এসো বাপ্পাদা আমাকে, বাপ্পাদা হচ্ছে ডক্টর ডি ঘোষ, মানে উনি হচ্ছেন অর্থোপেডিক সার্জন। বাপ্পাদা আমাকে খুব পার্ট ট্রেনিং নেওয়ার জন্য খুব এনকারেজ করেছেন।
স্বপন আমার কলেজের ছেলে, ভীষণ মানে কি বলবো, মানে বলা যায় না। আই হ্যাভ সিন ফ্রম মাই কোর অফ দ্য হার্ট। আমি এখানে 89-এ জয়েন করি, তখন আমি দেখেছি তপন ওই ঠিক ওর বাড়ির সামনে আমার বাড়ি তৈরি করছি, তখন থেকে আমি দেখেছি হাউ দিস ফ্যামিলি হ্যাজ এস্টাবলিশ দেমসেলস, লোকেদের কাছে কীরকমভাবে পরিচিত হলো। তখন থেকে আমি এদের সাথে ওতপ্রোতভাবে জড়িত। এবং ওর এই যে আস্তে 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 ও যে গ্রো করলো দুজনেই, আই এম ভেরি সরি টু সে যে আমাদের তখনও সেরকমভাবেই চলছিল, কিন্তু বাই ব্যাড লাক কিছু প্রবলেম হয়ে গেল। কিন্তু স্বপনের উপর আমার একটা বিশ্বাসও ছিল, এবং আই এম প্রাউড যে অ্যাজ এ ফিলসফার, গাইড, বন্ধু যাই বলুন স্বপনের কাছে, তার কারণ হচ্ছে যে ও আমার কাছে সব ভীষণ প্রিয়। কোনো একটা সময় যদি আমি ওকে একটা কোনো মেসেজ দিই, ইমিডিয়েটলি আমরা অ্যান্সার পাই। এবং ওর যে এই যে আস্তে আস্তে বেড়ে যাচ্ছে, এবং প্রথম আমি খবরটা পাই যে ও পাক ক্লিনিকের সাথে যোগাযোগ করছে, সে আমার খুব ক্লোজ ফ্রেন্ড, আপনাদের ওখানে এখনও আছে, অভিনব সেনগুপ্ত। হি ইজ মাই ক্লাস ফ্রেন্ড। তো ওর কাছে আমি একবার বললো ও যে তুই স্বপনকে চিনিস? আর আমি হ্যাঁ, কেন বলতো? বলছে যে পাক ক্লিনিক সব বোধহয় ওনাদের কোনো কথা হচ্ছে। আমি তো তখনই স্বপনকে ফোন করলাম, বলছি তুমি জানলে কোথা থেকে? আমি বললাম যাই নাই হোক, আমি এই কথাটা লিক করবো না আনলেস finally it is finalized. I'm really, really proud of you, Swapon. And give a good clapping hand for. We are proud of him from Malda as well as from all the doctors' fraternity. Thank you very much for your kind hearings.
Thank you, sir. Now may I request, as because we are running a little bit late, we are going to start our main program also. So may I request our guests to take the seats on the front row, please. Now before we begin the program, dear audience, I would like to take the opportunity to present a special video that marks the embarkation of a new journey. Please enjoy the video. Thank you.
In the year 1932, amidst the colonial era of British India, Captain Dr. Sushil Chandra Chatterjee founded a small healthcare institution took birth in the heart of Kolkata. It was called Park Nursing Home. It was later elevated into the larger facility known as Park Clinic. a super specialty hospital run by the charitable society Park Medical Research and Welfare Society. Over the decades, Park Clinic became a symbol of Bengal's medical heritage. From pediatric surgery and medicine to neurosurgery, from maternal care to complex surgeries, the hospital left an indelible mark on countless lives. It not only treated patients, but nurtured generations of doctors, nurses and caregivers built on compassion and ethics. After Captain Sushil Chandra Chatterjee, founder of Park Nursing Home, which later became Park Clinic, Professor Dr. Subir Kumar Chatterjee, the legendary pediatric surgeon, carried forward the torch. Under his guidance and with his two sons, Dr. Sudeep Chatterjee, renowned endocrinologist, and late Dr. Sandeep Chatterjee, eminent neurosurgeon, Park Clinic rose to become a true center of excellence in Indian healthcare. Through many ups and downs, the institution found within itself a renewed purpose, a quiet vow to continue its legacy of compassion and innovation. And today, that renaissance has begun, as Park Clinic joins hands with SonoScan, established with a mission to democratize advanced healthcare services. SonoScan has emerged as one of Eastern India's most trusted names in medical imaging and laboratory services. From Malda to Kolkata and Balurghat to Gangarampur, its network of multi-speciality diagnostic centers has redefined accessibility, accuracy, and affordability in healthcare. With state-of-the-art technology, including 384-slice cardiac CT, 3 Tesla MRI, AI-integrated radiology, and precision pathology, SonoScan stands for one ideal: to bring world-class healthcare services to every doorstep of Bengal. Now, with Park Clinic's century-old legacy joining hands with SonoScan's modern vision, a new era of integrated, patient-centered healthcare begins, one rooted in ethics, empathy, and innovation. From 1932 to today, the journey of Park Clinic tells us one truth: trust is the true essence of healing. And today, that trust ascends to a new horizon through the historic collaboration of Park Clinic and SonoScan, a legacy reinvented with modern mind.
নমস্কার, আমি ডক্টর সুদীপ চ্যাটার্জি এবং এই পার্ক নার্সিং হোম বলে একটি সংস্থা আমার ঠাকুরদা প্রতিষ্ঠা করেন 1932 সালে, এবং এটা সেই সংস্থার 92তম বছর। এই সংস্থা প্রথমে পার্ক স্ট্রিট, কলকাতার পার্ক স্ট্রিটে ছিল, সেখান থেকে কলকাতার ভিক্টোরিয়া টেরেসে স্থানান্তরিত হয় পার্ক নার্সিং হোম নামে। তারপরে সেটা পার্ক ক্লিনিক নামে কাজকর্ম করে, এবং কিছুদিন হলো আমরা সোনোস্ক্যানের সঙ্গে কোলাবোরেশন করে সোনোস্ক্যানের টেকনিক্যাল সাপোর্ট নিয়ে এগোতে চাই। সোনোস্ক্যান উত্তরবঙ্গ তথা কলকাতায় বহু প্রসিদ্ধ সংস্থা, যার কাজ এথিক্স, ইন্টেগ্রিটি নিয়ে সবাই ওয়াকিবহাল। আমরাও যে পূর্ব ভারতে প্রাইভেট হসপিটাল 92 বছর চলছে, আমরা ছাড়া আর কেউ সেরকম জায়গায় নেই, এটা আমাদেরও একটা গর্বের ব্যাপার। এবং এরকম দুটি সংস্থা যাদের জন্ম পশ্চিমবঙ্গে, এরা দুজনে হাত মিলিয়ে এগুলে আমার তো মনে হয় যে অসুস্থ মানুষ যারা আমাদের কাছে আসেন তাদের প্রচণ্ড সুবিধা হবে এবং খুব ভালোভাবে তাদের চিকিৎসা আমরা করতে পারবো ভবিষ্যতে।
So I am now inviting Sir Dr. Sudeep Chatterjee to start the session. Sir, please come on the dais and the session is yours.
থ্যাংক ইউ প্রথমে দুটো কথা বলতে চাই। প্রথমটি হচ্ছে মাননীয় CME সাহেবকে, যে আপনার মানে এই টেনিয়রে কালোজ্বর যদি মালদা থেকে চলে যায়, বিতাড়িত হয়, এটা যেমন একটা বিরাট একটা অ্যাচিভমেন্ট, তেমনি একটা দুঃখের ব্যাপারও হবে যে একমাত্র অসুখ যার নাম বাংলায় আছে সেই অসুখটা আমাদের মেডিকেল টেক্সট বুক থেকেও হয়তো চলে যাবে। যাই হোক, সেটা খুবই সুখের বিষয়। দ্বিতীয় হচ্ছে যে স্বপনবাবুকে বলবো যে যে কোনো কাজ আমরা যদি ভালোভাবে, ভালো মনে, ভালো চিন্তায় এবং ভালো উদ্দীপনা নিয়ে করি, সে কাজ সফল হবেই, এবং এটা তো কোনো দ্বিমতও নেই এ ব্যাপারে, তাই না? এটা আপনারা যারা আছেন এখানে এরা সবাই এই ব্যাপারে মানে আমাকে সমর্থন করবেন। যাই হোক, এটার পরে আমার যে লেকচারটা সেটা হচ্ছে থাইরয়েড আর ডায়াবেটিসের ওপর। এখন ইনফেকশাস ডিজিজ তথা কালাজ্বর যেমন আস্তে আস্তে কমে যাচ্ছে, নন ইনফেকশাস ডিজিজ কিন্তু তেমনি হারে বাড়ছে বা তার থেকে বেশি হারে বাড়ছে। এবং এই নিয়ে একটু আমরা যদি আজকে আধ ঘন্টা মতন আলোচনা করি, তারপরে কিছুটা সময় আছে, তখন আপনাদের প্রশ্ন যদি থাকে, এটা খুবই দরকার যে আপনাদের কথা, আপনাদের প্রশ্ন, আপনাদের ভিউ পয়েন্ট শেয়ার করলে, তাহলেই আজকের সেশনটা আমার কাছে সবচাইতে কি বলবো মিনিংফুল হবে। যাই হোক, স্লাইডটা কোথায় চেঞ্জ হবে? বলে দিচ্ছি এটা, না হ্যাঁ এটা দিয়ে, হ্যাঁ ঠিক আছে, ওকে। একটু যাই হোক, এই থাইরয়েড আর ডায়াবেটিস এই নিয়ে আমি ম্যাক্সিমাম কাজ করি, তাই এটাই আমার পক্ষে বলা সবচাইতে সহজ এবং মানে একদিক থেকে উপযুক্ত। যাই হোক, thyroid hormone comes from the thyroid gland. The thyroid gland, you know where it is. It's got two lobes and an isthmus. The two lobes are, each one is the size of your own distal digit of the thumb, as I've shown in the picture. That is the normal size of your own thyroid, i.e. the size of your own thumb. It produces two hormones that we are interested in. One is T3, which is just about 10%, and T4, which is 90% of the total production from the thyroid gland. And as you know, T4 is inactive. It is converted to T3 mainly in the liver and kidney, and T3 is the active hormone. Now, we talk about pregnancy. Pre-pregnancy, the target TSH is between 1 and 2, which is lower than the normal range, I mean the lower end of the normal range. Now, the thyroid antibodies are there in the blood, in Hashimoto thyroiditis, and that is thyroid TPO antibody and anti-thyroglobulin antibody, and if these antibodies are present, then there is approximately a 2% risk of miscarriage in the first trimester, and this cannot be reduced. Now, in the beginning of the pregnancy, HCG levels go up, as you can see in the little diagram on the left, on the right, sorry, where you can see that HCG in red going up, peaking at 10 weeks of gestation and then coming down. Now, what happens is that HCG has 1/800th the activity of TSH. So if you have a lot of HCG on board, then that is behaving like TSH, and that is stimulating the thyroid gland, and you can have a temporary rise of T4 due to this entirely physiological rise of TSH. Apart from that, the TSH will come down, and in general, in pregnancy, the TSH goes up every few months, and that is why it is recommended that we measure either free T4 or total T4 and the TSH every 3 months, and the dose is adjusted to keep the TSH in the trimester-specific normal range. Usually, as the pregnancy progresses, the dose can go up by up to 50% of the original dose, and it generally comes back to the pre-pregnancy dose after delivery. Now, this thyroid is of course produced from iodine. You need iodine to produce thyroid hormone. Now, in 2007, the WHO set goals for how much thyroid should be ingested, iodine should be ingested, and you can measure that by looking at urinary iodine. Now, this is interesting because we had a PhD student in nutrition who did this work in Ramakrishna Mission Shiva Pratishthan Hospital in Kolkata, which is supposed to be an iodine replete area because it is close to the sea. And out of 237 pregnant mothers, 37% were iodine deficient, which is quite a lot. And out of 73 lactating mothers, 33 were iodine deficient, and out of the non-pregnant women that we studied as controls, 3% were iodine deficient. Now, why is that? That is because in India, salt is iodized at 15 parts per million, and this is enough to prevent goiter and enough to prevent neonatal hypothyroidism in a major way, but not subtle way. However, the requirement in pregnancy is much more, 200 to 250 micrograms, whereas this 15 ppm will deliver only 150 micrograms per day. So there is actually a deficiency of iodine in pregnancy in our country, in an iodine replete area, in spite of having iodized salt branded. Example, in the US, the iodine in content of salt is about 3 times higher. That has its own problems, which we did not discuss right now, and of course it is more expensive, but this is just to point out something that you may not be aware of. Now, the neonatal thyroid actually starts work very quickly. From approximately 12 weeks of intrauterine life, the thyroid is formed, it starts working. However, the mother's thyroid also passes through the placenta. So, in case the baby is going to be born with iodine, thyroid deficiency, congenital hypothyroidism, the mother's thyroid keeps it going during pregnancy. However, at birth, in different studies in India, about 790 to 1,000, 1 in 790 to 1 in 1,000 babies are congenitally hypothyroid. The only way you can pick it up quickly is by checking the cord blood TSH at birth and of all the babies. So essentially, to detect one hypothyroid baby at birth, we have to screen about 1,000 babies. But this is actually very necessary, and it is done all over the world. It is done in India, but it is not a mandatory requirement at the moment, but it should be done. So this is just to show you how the fetal thyroid works. You can see it starts accumulating iodine from 10 weeks, then it starts secreting T3, T4 at 12 weeks, then the pituitary also develops, and the TRH comes from the hypothalamus that stimulates the TSH in the pituitary, and that then works on the thyroid, which is now developing in the baby's neck, and the whole process becomes mature by 36 weeks. And you can see at the bottom in the 2 triangles, the fetal thyroxine goes up as the fetal thyroid becomes more active, and the share of maternal thyroxine comes down as a result, proportionately, because the baby does not need a lot of thyroxine. It just needs enough, does not need a lot of thyroxine. It just needs enough to for its requirements, and that is adjusted by the TSH of the baby. Now, another interesting thing is this, and that is that the TSH levels change very dramatically at birth. At the bottom is days, And you can see that at birth, the TSH is very high. You can see in the arrow the black line, how high the TSH goes at birth. Then it immediately comes down and becomes pretty much around 10, around about day 3 or day 4. And I would just like you to concentrate on that single black line. But you can see, that the other thyroid hormones, everything sort of changes very rapidly from high values to what we call normal values within the space of a few days. Now, when you have a baby that is hypothyroid, we have to remember the mother has to give the baby the thyroid tablet. What they usually do is they crush the tablet, keep it in what is called a jhinuk, and then give it to the baby. Unfortunately, it is not very useful because nothing dissolves in the water. And actually the residue that remains in the spoon or whatever, that contains all the thyroid hormone. And it is not possible actually to normally dissolve thyroid hormone. It either requires alkali or it requires glycerol. However, the range, as you just now said, as I just now showed you also, that the range in babies is different from the range in adults, and generally treatment is not recommended unless the cord blood TSH is more than 20. And once we have decided to give the baby thyroid hormone, we require higher doses than for adults. If the treatment has been started inappropriately, for example, the TSH at birth was 10 or 12, which is higher than the range usually quoted, because the range quoted is the adult range, then sometimes the baby started on thyroxine. It's best to continue till age 2 years, because till then the baby's brain development critically depends on thyroid hormone. I'll show you in a minute. Therefore, if it has been started and you think it is not appropriate, wait for 2 years, it doesn't harm the baby, and then stop and reassess. Typical dose is 8 micrograms per kg. So what I tell the patients is that you crush the crush the tablet, mix it in very light syrup. If it is dense syrup, then it might even form a sort of a solid mass and can be aspirated. So very, very light syrup, and insert with your finger inside the cheek, and that works best. So what happens in the first 2 years is that this is how the brain is diagrammatic representation. Basically, the neurons need to talk to each other, need to have networks established. And you can see diagrammatically from a very basic network, the network becomes more complex over 2 years. And this is the time when thyroid hormone is crucially necessary. If you don't have it, the brain size will remain the same, but the critical networking between the neurons will not happen. And that has it. And so therefore, congenital hypothyroidism is the world's easiest to treat mental disability. Now, diet. So whenever a thyroid patient comes, this is their main concern, because if you look at the internet, there are about 20 to 25 sites which talk about diet. All rubbish. But they are there, starting from apple, going down to whatever zucchini, everything is forbidden in some site or the other. So you can see on the left, they are saying bad and good, and you can see good is shown as cabbage in the left hand side. It is shown as bad in the right hand side. And you have said we got foods to avoid: gluten, that is wheat, cruciferous vegetables, sugary food, fatty food, processed food, coffee. It goes on and on. All rubbish. So I tell the patients, please go to either the British Thyroid Association website or the American Thyroid Association website. Unfortunately, the Indian Thyroid Association does not have a website of this nature. There is no mention about food, not a single line, because food is not something that they feel a recommendation should be made about. It's not relevant at all. Anyway, but it's a patient concern, and it's a patient concern fed by modern day technology as well. Another interesting about TSH, and we'll go digress a little bit and talk about normal ranges, say normal range for blood glucose or blood urea, because these things are normally distributed. The normal range is usually a mean plus or minus 2 standard deviations. But for thyroid, if you did that, you see the bell-shaped curve on your left. What is going to happen is that the normal range will end somewhere around 3, 2.5 to 3, the bell-shaped curve ends. But that will actually produce more agony, more anxiety, that you have an abnormal thyroid. It can be now written in bold in most lab reports and so on. So more or less by convention, there's a long tail, and the normal range of TSH actually ends somewhere around 4 to 4.5, which is not exactly a bell-shaped curve, as you can easily see. The other thing is about extremes of age. TSH normally goes up with age. It's a normal phenomenon, and you can see on the right-hand side, the TSH is there, age is at the bottom in the x-axis, and say from age 70 onwards, the TSH normally goes up. These are normal people in their mid-60s to say 80s, and you can see in the US population, they have a TSH that can be 10 or even up to 14, and there's nothing wrong with them. This is a normal aging phenomenon. So this also has to be borne in mind. Another thing that has to be borne in mind, it's a bit complicated, the slide that is. Basically, the T4 and the TSH have a log linear relationship, which means you can see on the x-axis at the bottom, we have the T4 or the T3 in picomoles and nanograms. And on the y-axis is the TSH. The TSH is a log scale. You can see that, well, if the TSH is 100, if you go to the bottom, then the T4 would be somewhere around, say, 0.9, 0.7 or 0.6. From 100, when the TSH drops to 10, the T4 just changes a little bit. And that is because there is a log linear relationship between the T4 and the TSH. So if you have TSH, say 100 or 80, and you want to treat, don't give a very high dose. The dose does not depend on the TSH value. The dose depends on the body weight, typically 1 microgram per kilo. And because of this log linear relationship, it's best not to increase the dose very rapidly. I mean, you don't go from, say, 50 micrograms to 100 micrograms, because that will produce a log change in the TSH. So you have to go very slowly. The smallest tablet available is 12.5 microgram, and that is good enough. So if you change that, then you have to wait. For the T4 TSH system to stabilize on the new dose, we need at least 6 weeks. So after that, if you're still not satisfied, if the TSH is still high, then think of another small increment. So what happens if you have a TSH beyond the normal range, as shown in that big tail in the earlier slide, say 4.5, instead of 4.5, say the TSH is 7. TSH is 7 or something. What is recommended? You see, this is what the American Thyroid Association recommendation is. Every thyroid association has the same recommendation, that if there is a TSH up to 10, there is no real need to treat, except if it is a woman contemplating pregnancy. There's no benefit. The other problem is that if the TSH is a little bit high and the patient has a cardiac issue, then it is perhaps worth treating. So this is what is shown here in this particular study, and you can see that between euthyroidism and subclinical hypothyroidism, it's a TSH on this, say 10, you can see the cardiovascular composite of cardiovascular events. Composite of cardiovascular events is very different between a treated patient or a euthyroid patient and a subclinical hypothyroid patient. So basically, what have we learnt from the thyroid part of the talk? TSH values in the newborn are higher than in adults. When in doubt, treat the baby till 2 years of age, then stop and reassess. Subclinical hypothyroidism is the easiest to treat cause of infertility or subfertility, as we now call it. In fact, we did a study with late Professor B.N. Chakraborty, and we found that really, at least in our setting, the most successful, commonest intervention one could do for a subfertile woman was to give her thyroxine if she had a slightly high TSH. The target in before and during pregnancy is a little different. We want to keep the TSH between 1 and 2. And don't treat TSH unless it is more than 10. Treat under 10 TSHs if there is underlying CHF. Normal value in the healthy elderly are higher than what the labs tells you. Right. So that is about this part. Now, the next part, which is a completely different topic, that is diabetes. We'll go into that. And let's see what the American Diabetes Association has to say, because that has been included in the topic. Well, it has got a lot to say, as you can see. There are about a whole number of points, starting from improving care, promoting health, diagnosis and classification, prevention and delay, goes on to diabetes technology, chronic kidney disease, retinopathy, and so on and so on. So it has a lot to say. It doesn't say much many new things about medicines, because that's more or less done and dusted. It's now talking about things like ambulatory monitoring, where the technology is available and changing and improving. It talks about dental health. It talks about adequate sleep, adequate exercise, and it talks about overweight. So these are the new sort of touch points so far as the ADA is concerned. Well, I will just not talk too much about this, but just share with you what happens when a diabetes patient first comes. And incidentally, the current way of talking about them is to talk about people with diabetes, PWD. Not the ones that make the blue buildings, it's people with diabetes. So basically trying to say that it is not a disease, it is a sort of a lifestyle issue, and it should be treated or thought of by the patient in that sort of way. So, but for the patient it's very different. For the patient who is newly diagnosed to have diabetes, the first consultation is absolutely crucial. Why? Well, the diagnosis is devastating to the patient. And from the patient's point of view, it is like the patient has lost a limb, or lost an eye, or maybe lost a loved one. And they are actually very depressed. So first thing is to acknowledge that yes, you are depressed. Every single diabetic patient who first learns about diabetes is depressed. And because the incidence of diabetes is about 10 to 12% in the urban population, in this room, there will be at least, well, maybe 15 or 16 people with diabetes. And they will know it better than I do. So it is depressing in the beginning. Then what do you tell the patient? You have to tell them, living with diabetes, keep diabetes under control. How do you frame your responses? So my way of doing it is that tell them that let's lead a normal life with diabetes, and we'll guide you how you can lead a normal life with diabetes. Keep diabetes happy and lead your life. We have a brief discussion about meals, because by the time they come, they have practically stopped eating everything. They're eating only water and some corolla and some methi, and they are managing somehow, and that's all they're eating. So I tell them, if you follow everybody's advice, all the people you have met, starting from your friend and your neighbor, then ultimately we'll only have meat patkil and water and nothing else. So be practical, and let's talk about diet, about meal plans, and meals, and explain to the patient that we don't have to have emergency control of blood glucose for a type 2 diabetes. We will go slow, but we do not want to cause any hypos. And we talk a bit about the natural history of diabetes right from the beginning, because this is important. Because patient will usually says that we will not have medicines because once you have a medicine, you have to have it forever, and so on and so forth. You know all these things, it's very common. And they talk about natural foods. In South Asia or in the Indian subcontinent, there are at least 500 natural products that can lower blood glucose. Some of them are given in this diagram. Trifol, of course, is 3 things together, buy 1 get 3 sort of thing, and there's no end to them. So the problem with natural foods is that they are not standardized. The methi that you have had today will contain a certain amount of glucose lowering substances. The same, say, 1 spoon of methi you have 3 months later will definitely have a different quantity of the same substance. And it has been shown that between winter and monsoons, the amount of the glucose lowering property of, say, a spoon of methi varies by a factor of 2. I mean, 50% lower dose amount of medicine is present in winter. So it is not a standardized product because nature cannot be standardized. 2 corollas can never be the same. So we have to realize that foods are excellent, but they have a problem of standardization, and that should be kept in mind when you have it. So I prefer that you have it as a food, but don't have it as a medicine, because the dose of the medicine will vary. And I'm sure you can understand that. So that is a point that I tried to make in the first consultation. Then we'll talk about oral agents a little bit. So this is what the ADA says. You first determine the target HbA1c you want the patient to have. It is usually about 7%. Well, if the actual HbA1c of the patient differs by more than 2%, start with 2 drugs is the recommendation. And if the fasting glucose is more than 300, start with insulin. And it does not mean you have to have insulin forever. It can be stopped. But at this point, the patient is dehydrated, having polyuria, polydipsia, and is symptomatically quite unwell. And giving them insulin immediately stops their symptoms. Whereas if you start with an oral agent, you're not going to get any response. With the quickest of the oral agents, which will be sulfonylureas, actually, it will take about 2 weeks. The other point is, this is a bit odd, but the data is there that if you start initially with insulin for all patients, it appears to prolong the life of the beta cell of the patient. The best drugs at the moment, I would say, if you have to start with 2 drugs, are metformin and a DPP-4 inhibitor. If there is ASCVD, that is atherosclerotic cardiovascular disease, then the recommendation is that you do not start with metformin, but you start with either a GLP-1 receptor agonist, which is expensive, or an SGLT2 inhibitor, because they have been shown to have a beneficial effect in ASCVD. So this is a paper from China published in Lancet in 2008. And here they took newly diagnosed diabetes patients and they gave them either oral agents, it was glycoside, or they gave multiple injections or an insulin pump. And once the blood glucose came under control, then they stopped the treatment. And after stopping the treatment, they wanted to see how long the patient would remain at quote-unquote normal levels of blood glucose. Eventually the blood glucose will go up, no doubt, but how long will that be? So what they found, you can see here, in the green line is that the patients who had oral agents and then stopped relapsed very quickly. The patients on an insulin pump relapsed the slowest. i.e. they seem to keep their beta cells going for the longest. It's not that it is practical to do in every case, but it is just to know that if we start insulin in the beginning, and there are patients where I have given, say, 10 units of glargine for 30 days, which is basically one disposable cartridge, 300 units. And these are the patients who are a little research oriented and they can sort of interact with the net in a meaningful way. And I tell them that I would suggest this, and you look it up. If you think it is worthwhile, you do it. But if you don't think it is worthwhile, because they're very scared, a lot of them are very, very scared of insulin. Obviously, I mean, they are human beings. So then we'll go with the DPP-4 and metformin. Now, this is the problem with the beta cell, that it stops working. So there are certain temporary reasons for it to stop working. You have the top two, that is glucotoxicity and lipotoxicity. Then there is stressed endoplasmic reticulum, mitochondrial dysfunction, oxidative stress. Then there's a little bit of inflammation that also can go away with treatment of diabetes. And there's amyloid polypeptide deposition. So all these things sort of cause the beta cell to fail, and as the beta cell fails, you get more of glucotoxicity and lipotoxicity. So it is sort of a vicious cycle, which of course you can break by lowering the blood glucose, and you can remove the glucotoxicity or reduce the glucotoxicity, lipotoxicity, and the inflammation part. That is being shown here, that once the glucotoxicity, lipotoxicity, and the inflammatory part is attenuated, then insulin resistance comes down, endothelial dysfunction improves, and the beta cell also recovers a bit of its function. So a patient who has been maybe on two oral agents to begin with, after say 3 months or 4 months, can manage with one oral agent, or maybe with diet and exercise alone for some time, but not forever. Why not forever? Because of the natural history of diabetes. And what is the natural history? You can see, first let's go to the bottom part where you can see 0 years is here, and diabetes, this is pre-diabetes, this is 0, and you can see at 0 the beta cell mass has come down from its peak, it's there, and the beta cell mass declines with time. Typically, at the time of diagnosis, 50% of the beta cells are lost, and the remaining 50% will slowly lose their efficacy with time. And you can see in the top graph what happens is that both the postprandial glucose in green and the fasting glucose in purple or pink, they keep going up with time, and they sometimes reach diabetes levels well before the diagnosis of diabetes. And then if you don't do anything, the levels keep climbing. So this is the natural history, and of course they will keep climbing because the beta cells are progressively failing, and the high glucose is adding to the lipotoxicity and glucotoxicity, making it worse. So what about the anti-diabetes agents that we have? We know metformin is the first one that we use. They have GI symptoms, the patients. They mostly resolve in 2 weeks' time. With the DPP-4 inhibitors, there are skin rashes, very rarely, but they again resolve. And in fact, it's the least, I would say, side effect prone medication to use. And I don't know what you find, that I find, at least in Kolkata, is the side effect capital of India, and where patients, whether the medicine has any effect, it's not so much of an issue, but whether the medicine has a side effect is a very major issue. Anyway, with the SGLT2, you have weight loss, which is fine if it happens on the tummy, but it is not fine with the patients if it happens on in their face. And you cannot choose where the weight is going to be lost from. It's genetic. So, and then there are genitourinary infections, and there are pleiotropic benefits on the heart and the kidney, but those are long-term and the patient cannot see them, if you know what I mean. With the GLP-1 receptor agonist is the cost and the choice of agent, because the companies themselves keep confusing us. Once the patent of, say, liraglutide is over, then the company itself promotes studies showing that liraglutide is not very useful. In fact, we now have generic liraglutide. Similarly with dulaglutide. Now, the problem with SGLT2 inhibitors and balanitis is actually quite a lot in India. And this is a study from 2025 looking prospectively, on the right-hand side, looking prospectively at 200 patients in Karnataka state. And they found that genital infections were there in 30% of males and 36% of females. Now in the US, where most of the original studies were done, as of now, 80% of the males are circumcised because insurance allows payment, gives payment for circumcision. So almost all males are circumcised for no real good reason. I mean, except for the religious ones, the non-religious reasons are basically non-medical reasons. So there, with circumcised males forming the bulk of the male population, the rates of balanitis, so the published rates of balanitis are low because the rates are published mainly based on this population, either US population, and the rates can be as low as 1% and in some studies up to 10%, which is really not the situation in India. So I do tell the patients that the medicine is good for you in many ways, but if you have a problem, please let us know and we will stop the medicine. And they do that. Now monitoring is very important because, you know, unless you actually see the blood sugar report, you don't know what's going on inside. So the fasting and PP have to be done. When oral agents are used, the surprising finding is that the meters don't improve outcome. The meters increase anxiety and the meters don't seem to do much good so far as measurable outcomes are concerned, though in remote areas or far off areas it's better to have a meter rather than nothing. And once a meter is used, the patient has two issues. One, the meter is false, meter gives wrong readings. Now the meters are manufactured to an ISO standard of 2013, which says that the meter reading can be plus or minus 15% of the actual reading. So that's a given. Now, and when they decide, the patient decides quite inaccurately that the reading is wrong, then they say that the meter is at fault. But the meter is rarely at fault. The strips are manufactured to this plus or minus 15% error. You can manufacture a strip with 1% error, but the cost of the strip will be about 10 times more. So the problem is actually with the strip, and it is designed for this plus or minus 15% as a sort of compromise between cost and accuracy. But the meter is not wrong. So patients often say, I'll change the meter, and I've again changed the meter, again it is wrong. But you know, so it's best to clear up as many of these myths right in the beginning. Frequency of follow-up depends on the patient. Most patients will never come back unless they have a problem, or they have a cataract surgery or something, then they want to come. But that is the way human beings are. We'll talk a little bit about the incretin system. Now you can see on the left, this is the GI tract, and you can see the colon in purple. Just above the colon we have the ileum in sort of a bluish green, and there the what should I say, the GLP-1 comes from. GLP-1 is secreted by the ileum when it sees a carbohydrate load. So if a lot of carbohydrate descends on the ileum will secrete a lot of GLP-1. So you can see that on the right hand side. The GLP-1 then goes into the portal system. In the portal system, it goes right around the circulation and then comes to the arterial system to the pancreas. That will take about 1 minute. Then in the pancreas, it will promote release of insulin if the blood glucose is high. If the blood glucose is normal, it doesn't work. If the blood glucose is high, this GLP-1 will produce insulin from the pancreas. It has a half-life of 2 minutes, so you cannot use native GLP-1. So you can either use an enzyme that will prevent the breakage of GLP-1, which is the DPP-4 inhibitor, or you can use analogs of GLP-1, which behave like GLP-1, but which act for maybe a week. So that is what happens in diabetes reversal. This is again something that is very much a part of the internet culture. And there's a surgical way of doing it. What you do is that as you can see on the right hand side, that you make a small pouch, and first of all the pouch prevents overeating. Second, it delivers a lot of food quickly to the terminal ileum. So when a lot of food or carbs come to the terminal ileum, so there's a much bigger GLP-1 response from the ileum than had it come to the duodenum, jejunum, and then ultimately to the ileum. You can get the same effect with weight loss. And weight loss, so this is one study on the right hand side done by a colleague of mine from Newcastle. So he produced a massive weight loss of about 15 kilos over 8 weeks, which is not practical, but just to show as a proof of concept that it could be done. Within 7 days, liver fat had fallen by 30%, fasting glucose had normalized by 8 weeks, pancreatic fat returned to normal, and insulin secretion by the pancreas returned to normal. And as long as the weight could be kept down, there was in effect a diabetes reversal. And that is because insulin resistance comes down. And of course, if you lose even 500 grams, there's 500 grams less for the body's beta cells to service. So, what about the future? Future, there's no end to the number of things that are being done. So, technical advances in monitoring, in pumps are going on all the time. There are pumps with a GPS now, where the pump will track whether you are going to a restaurant or not. And the pump can be preloaded with the menu of the restaurant. And the pump can sense the movement of your hand to see what you're eating and how much you're eating, and make informed guesses about what actually you're up to. There are longer acting insulins, 1 week, 1 month even. And there are insulins that can be activated by hyperglycemia, which is very good if it becomes reality. And there are insulins that are activated in the liver, which is what nature intended insulin to do, because in nature the insulin comes from the portal vein directly into the liver, but we inject it subcutaneously. So we are trying to, scientists are trying to, get insulin which is actually activated in the liver. Insulin delivery methods are changing. New inhalation device has come into the market, not yet marketed, but they have got permission in India. Then there are oral insulins, buccal insulins. Patch can come. Patch is actually a patch with very small microscopic pins, smaller than a human hair. You don't feel the pins, so you have a small reservoir of insulin and you can slap it down, and the small pins go into the subcutaneous tissue. And beta cell regeneration, which is the holy grail. And there are actually compounds that can produce beta cell regeneration. And these compounds are present in a enzyme called DYRK1A. Now, if this enzyme is inhibited, then the beta cell seems to regrow. And incidentally, this compound is present in many natural products, all available. Some of them are available in India. Some of them are marketed for various Ayurvedic issues and all that, but they don't contain a lot of this particular compound. It's called harmine, but it's there. So we also can actually pick this up and do some really good path-breaking work on it. Now, I don't know whether we have some time, but I'll just spend a few minutes on a patient that I recently saw. This is nothing to do with the topic, but peripherally. So this is Dr. DPC, 82-year-old retired surgeon from the US. He's ex-NRS. He calls me by my first name. He's diabetic for 20 years, comes once a year, sees me when he's in Kolkata. He's on Glargine and Humalog. HbA1c is 8.4. He has a mild iron deficiency anemia. Well, One day he came for a semi-urgent consult. He's feeling weak. From a hemoglobin of 11, it has dropped to 8.1. Serum iron is low, TIBC is high. So I said, we have to do a colonoscopy, we have to see why you have got iron deficiency anemia. He said, no. I just want IV iron, that's exactly what I get in the US. You just give me some intravenous iron and let me go. So I said, let's have an upper GI and a lower GI endoscopy. He was very angry, don't waste my time. This has been done many times in the US. He hadn't heard of capsule endoscopy, but he refused it anyway. But he agreed to a very old-fashioned test. And this is a barium meal and follow-through. I was feeling that I will do nothing. The patient is 82 years old. He has iron deficiency, anemia, male patient. And I can't just leave doing nothing. So we agreed to the barium meal. And this is what the barium meal showed. And if you can see the abnormality, that's great. If you can't, I'll just show it in the next slide. So he actually turned out to have a Meckel's diverticulum. And just imagine at the age of 82, he has a Meckel's diverticulum. And of course, that solved the problem at least, but I was really amazed to see that that is what he had. And just to summarize, this thing is not, it affects 2% of the population, it's about 2 inches long, occurs 2 feet from the ileocecal valve. Male patients are 2 times more affected. Patient's age is always more than 2 years, but not 82. And only 2% of patients are symptomatic, which this one was. So with that, I'll end my talk. Thank you very much. Thank you, audience. Thank you so much. Any comments or questions would be very welcome.
Sir, you mentioned that in elderly population the TSH level goes up with aging. So consider a scenario, 80 to 90-year-old person comes to your chamber and complains of some cognitive, more specifically memory issues. And you run test and TSH level comes between 7 and 8. In that scenario, would you recommend thyroid hormone replacement, or how you go about it?
No thyroid hormone replacement at that point of time, because most of it is actually Alzheimer's, and 7 or 8 will not produce any symptoms. Symptoms, you need at least a TSH of 15 plus. Now, the other thing is that supposing you have any acute non-thyroidal illness, supposing you have just flu or even dengue, in the recovery phase, you can have a temporary rise of TSH, which will revert to normal within 4 to 6 months. So I would say in this particular patient that there is no benefit to treatment. There's no point raising the hope falsely of the patient as well, because you know it won't work. I say, let us get a thyroid antibody to see if there is any chance of progression, and we will repeat the test after 4 months and then take a call. And well, that seems to satisfy both the patients and the cause of science.
Thank you so much.
Sir, what is the present status of T3 replacement in hypothyroid management?
T3 replacement, see, studies, T3 tablets have now become available in India, incidentally. And T3 replacement studies have shown no beneficial outcome when they are done by independent bodies. But there are some pharma-sponsored studies which show that there is an apparent benefit. But I'm not convinced that there is actually any benefit.
Degeneration of the beta cells.
See, the medicine does not fail. The medicine is as good as it was. So the failure is in the beta cell. And it is not that the beta cell always dies. About most of the beta cells just become inactive. And they actually behave like delta cells, which are inactive cells. But so it is actually a failure of the beta cell to function, rather, but there's no failure in terms of the medicine.
Okay, but what is the rate of decaying of beta cells with the increasing age?
This is, first of all, this is very individual. There is actually no method by which you can measure the beta cell mass of a living person. They are all guesswork. And some of the guesswork is actually done by pretty obsolete methods. For example, the insulin has to be measured by RIA, which nobody does anymore. So actually, the beta cell mass of a patient is difficult to estimate. One can estimate maybe HOMA-IR and so on, and get some guesswork idea of the beta cell decline. But basically, the idea should be whatever the rate of decline is, it is there, number one. Number two, you can reduce the decline by reducing glucotoxicity and lipotoxicity. If you keep the HbA1c around 7%, you're less likely to have beta cell decline, less steep beta cell decline than if your HbA1c is say 10%. So controlling the blood glucose, controlling the lipid, and then hoping for a best outcome.
Thank you, sir.
Good evening, sir. Sir, is there any cutoff for a pre-operative patient for any TSH level? Because, sir, we get most of the times patients having TSH
yes.
7 or 8, the patient is got unfit in the
Exactly. It is no reason, because see what happens is that if the patient is hypothyroid, then the problem is that post anesthesia, it is general anesthesia, then there is a slower rate of recovery, and there can be some hypotension after the anesthesia, after the surgery is over. Now, this is not actually due to the TSH, it is due to the low T4. And a TSH of 7 or 8 will make no difference. However, there are situations, say the TSH is at 30, and patient has to have surgery for whatever reason. We don't have to wait for the TSH to normalize. We really have to wait for the T4 to normalize. And for the T4 to normalize, if you start treatment, within T4 has a half-life of about 5 days. So if you go 2.5 half-lives, say maybe 2 weeks, you will get normalization of the T4. But for the TSH to normalize, it will take at least 6 weeks. You don't need that. So one is, for minor elevations of TSH, there is, it's totally irrelevant. Major elevations of TSH backed up by a low or subnormal T4, one should try to normalize the T4, and if the patient wishes to wait and the surgical team wishes to wait for the TSH to normalize, that's fine. But there is no medical reason for that. Medical reason is that once we have given adequate thyroid for 2.5 half-lives, then you will get a normal T4 level, and that will keep the patient safe during anesthesia.
So sir, the actual sir now most of the time, sir, if a patient we get a TSH of 25 or 20, so in most of the times we tend to give L-troxin of 75 or 100 micrograms. So that
you should give, no, you should give, see, if you wish to treat with a TSH more than 10, I think treatment should be started.
Okay.
There's only one caveat which I just now mentioned. I'll just repeat that. If the dose is dependent on the body weight, a 75 microgram dose is okay for a 70 to 80 kilo person. But if the person is say 50 kilos, then that is too high a dose. The dose does not depend on the TSH. The dose depends on the body weight, and there are temporary rises of TSH, recovery after thyroiditis, recovery after non-thyroidal illness. If you have dengue today and you measure the TSH after 2 months, you will have a high TSH, which will again normalize. So the temporary rises are there, and however, you can also get a thyroid antibody done, which will perhaps show that the TSH rise is going to progress. So these are some things you can do.
No, so sir, it is not. So we will not try to come to the normal TSH within 7 days or 10 days.
It cannot happen. It will never happen.
Will never happen.
It will never happen. It can only happen if it is very toxic and very high doses. It will still not happen because the TSH comes from the pituitary. And the pituitary will not normalize till 6 weeks are over. It will come down, but it will not normalize.
Thank you, sir. Ma'am.
So in pediatrics, usually in infancy, we directly start at 8 to 10 per kg. But if from which age there should be gradual increment, not 8 to 10 or like that.
Now, if you have congenital hypothyroidism, what has been shown that even with the best treatment in the world, starting from the delivery room, if you start treatment, for example, you will still have mild cognitive impairment, unfortunately. So the trend is to give a high dose in the beginning, straight away, and then maybe come down on the dose with passage of time. The whole idea, people think, there's no controlled trial on this, people think that since the baby will have some cognitive impairment, so let us try and rectify it with a higher dose. So this is the convention all over, that you give a much higher dose than usual.
Thank you.
So as an orthopedic surgeon, I used to get lots of cases of cerebral palsy. So when I get these patients of cerebral palsy, sometimes I ask them whether there is a birth asphyxia or not. They said no. Then at that time, sometime I find there is hypothyroidism in them. So is at that time whether thyroid hormone can be given?
See, to give, first of all, cerebral palsy is almost never associated with birth asphyxia. And it's a very heterogeneous term as well. Now, if you have a TSH which is more than 10, we will treat. But after 2 years, brain development is complete. All these networks have been set up, or the networks have failed to be set up. Now, if you have a TSH of say 40, and you have a 4-year-old child, at that point, whatever cognitive impairment has occurred. If the hypothyroidism has been congenital, supposing the hypothyroid occurs after 2 years, so 2.5-year child gets hypothyroidism and at 4 years comes with a TSH of 40. Then if you normalize, you will normalize the cognitive function, because at the time of brain development, the TSH was hopefully normal. The problem that these children actually come with is actually short height.
মায়ের বয়স 77 আর ওজন ধরুন 50, TSH অ্যারাউন্ড 10, তো মা 50 থাইরোনাম খাচ্ছেন, ওটা কি খাওয়ার প্রয়োজন আছে না স্টপ করে দিতে হবে?
এটা মিটিংটা হয়ে গেলে একটু ডিনারের সময় আপনার সঙ্গে ডাইরেক্টলি কথা বলে নেব, if you don't mind.
So one question from my side. Thank you very much for your nice presentations. It was very excellent, elaborative and very precise. And being a gynecologist, we do routine TSH testing in antenatal mothers. So my question is, what is the role of thyroid antibody testing in screening and diagnosis of hypothyroidism during pregnancy?
See, after the first trimester, getting the thyroid antibody will make no material difference to the pregnancy. Before the third trimester or pre-pregnancy, if you have a consultation and if the thyroid antibody is positive, then the data shows that you have a slightly increased, maybe 2% increased risk of miscarriage in the first 3 months. Even if you have normalized the TSH. With a normal TSH, you will get a 2% miscarriage rate, and treating the antibody with steroids, etc., has got no value. So thank you very much. Thank you, audience. I really, okay. I think one last question, I think.
Very good evening, sir. Sir, how much the HbA1c report, according to the American Diabetic Association, as well as our Indian diabetic patients, HbA1c
HbA1c recommendation is to keep it just below 7%. There is one caveat: about 10% of the population in Eastern India are thalassemia carriers. And there is one study to show that about 15% of the population are alpha thalassemia carriers. And here, because the RBC lifespan is reduced, the HbA1c may not be a very good marker. However, our RSSDI as well as all professional organizations recommended recommended HbA1c of under 7%, unless there is gross comorbidities like say a bad stroke or extreme heart failure, where you don't have to bother so much.
In our regular practice, I have seen too much patients who is controlling their HbA1c level is in normally in 7 to 8 or 9, but their fasting or PP blood sugar is high. Then what is the main scenario of that in case?
Two things. One is that of course there can be a hemoglobinopathy, and you can only pick up some abnormal hemoglobins, and particularly hemoglobin E. Hemoglobin E is not supposed to affect HbA1c measurements, but they actually do. And you can do an HbA1c to see if there is beta thalassemia. And the other problem is that sometimes the patient comes very late to the lab. Say you have had the medicine in the morning, next day you come to give the fasting blood at about 12 o'clock. The fasting sugar will go up. The fasting sugar ideally should be measured say 8 to 9 hours after the last meal. And that is actually not possible to do it in the lab, because that means coming to the lab at about 6 o'clock or 7 o'clock in the morning. So after that the sugar can just drift up. That's quite possible.
Thank you, sir.
Thank you. Thank you very much. Thank you.
Here and being witness to a very interactive scientific session on two important issues, thyroid and diabetes. Thank you all again. A good night and enjoy your dinner in the next room.